So good afternoon, you panel, dear colleagues. It's my pleasure to be here and close this interesting session. These are my disclosures. So the World Health Organization defines the young adults to those with less than 60 years old adults to those between 60 and 74, and elderly people to those with more than 75 years old. As we know, stress urinary incontinence prevalence increases with age, and nevertheless, we will offer the same treatments, pelvic floor training or surgery, to this lady regardless her age. So the aim of our study was to analyze the long-term efficacy and safety of a single incision sling, ALTIS, in all women suffering from stress urinary incontinence. For that, we designed this prospective, observational, and single-center study where we included patients with stress urinary incontinence or mixed urinary incontinence with predominant stress urinary incontinence. All of them underwent single incision sling surgery. Finally, we had 110 patients fit for analysis and stratified according to this World Health Organization classification. We study efficacy with objective negative cough test in the office or ICIQ equal to 0, and the satisfaction according to an analogical scale from 0 to 10. And safety was studied with a Clavien-Dindo classification. These were our results. We had 11% of elderly people with a mean age of 78 years old. Our follow-up was nearly 3 years, and we didn't find any difference in the pre-op data according to BMI, number of vaginal deliveries, or pre-op urgency between groups. Regarding objective cures, we found no difference between the elderly woman with the other rest of the groups, and this objective cure was maintained throughout all of the follow-up. When we talk about it's different because when we talk about satisfaction, we found a high satisfaction rates with the surgery, and even it was high in the elderly people, 9 out of 10. It was statistically less than in the other groups. And what was the reason? We didn't find any difference between complications. We have had not yet any exposure. But what about urgency? Maybe that was the clue. From the 110 patients, 50 didn't had pre-op urgency. We didn't find any difference in the evolution of the urgency, even it was cure or persistent. But from the patients that didn't have urgency preoperatively, we find that elderly people develop statistically higher rates of de novo urgency. So we conclude that this procedure is effective and adequately safe for the elderly people. Objective cure rates are similar than non-elderly, and subjective satisfaction is high in this range of age, but we have to properly advise our patients that in this range of age, there's a high risk of de novo urgency. Thank you.
Abrahams, Bristol. Can you say what objective cure means?
Yeah, we define that as a negative cough test in the office.
I mean, this is not really the way we do things now, is it? Mm-hmm. We use patient-reported outcomes, and we ask the patient whether they're dry.
We use also the ICIQ, sorry.
So what was the results of that, in terms of patients saying they were dry?
As objective cure, we use the ICIQ or the negative cough test. I don't have the data separately.
Because it's quite confusing for you to present this. Because as I said, we now would more or less always look at patient-reported outcomes. And the studies that have used patient-reported outcomes show that only 2/3 of women are cured by tapes. Now, okay, this is a different tape. But in fact, the mini sling, is this a mini sling?
Mm-hmm. Yes,
so the mini sling is, in fact, according to NICE, in the UK should not be used because the results for mini slings in general are not as good as the results for the other plastic slings. So can you explain why your results are so much better than anybody else's?
Well, I don't think those are the best results. That was not my message.
No, well, they are the best results. I haven't seen results like this since results from Southern California about 30 years ago that the senior members here will remember.
We had nearly an 85%, I think, 86% of global objective cures. We don't think that this is the best way. We have not the best results, I think, but we have 3 years of follow-up. These are our results. We don't use more the TOT because of pain. We have less rates of pain with this sling. And, well, that's my point.
Can I just make one other point? The global result is worse than any of the 3 subgroups. Is that mathematically possible?
Maybe the old adults were the greatest, well, the young and old adults were the greatest group, and maybe that decreases that figure.
So could I ask, you showed us that more older people had more de novo urgency. You showed us, and you showed us that older people were less satisfied. You didn't relate the two.
No, we didn't find a relationship, maybe because there were only 2 elderly people with de novo urgency, even though it was a high percentage.
Is a reduction of 0.07 in satisfaction meaningful at all?
Sorry?
So your visual analog scale reduction of 0.07, is that actually clinically meaningful at all?
No.
Did those people that put 0.9 say that was bloody awful?
No, we make that analysis because we had this statistically difference, even though we think it's not clinically important.
Thank you. That's good.
Welcome.
Any final comments? Looks like you're a good escape. Thank you.
Yeah.